Are you considering building or enhancing your existing specialty program? Our CHAP Center for Excellence Disease Program certifications provides your agency with a set of standards written and vetted by clinical industry experts. Our certification demonstrates you are committed to the highest standards and quality recognized by CHAP. Certify and differentiate your program from the competition.
Greetings and welcome to episode 2 of CHAPcast. I'm Jennifer Kennedy, Vice President for Quality and Standards at CHAP, and I'm so pleased to be joined with our National Medical Director at CHAP, Khai. Khai, can you give us a little bit about your background?
Well, thank you, Jennifer. Great to be a part of this episode. A little background for everyone. My name is Khai Nguyen. I am a geriatrician and, as Jennifer stated, National Medical Director here at CHAP. My background primarily is in geriatrics, internal medicine. So clinically is still one of my greatest pieces of my work that I still do, in addition to the health policy work and the work that we do in quality here. Um, I, again, came from a public health background as well, in health policy, and that was added to my clinical credentials. So I kind of think of the world in that way, both from the clinical standpoint and sort of in a public health way as well.
So, yeah, I appreciate your love of public health. I've spent most of my 35 years of nursing out in the community, and I think that's really, to me, the best place to be. It's where people live and do their everyday thing, and why should not healthcare and care in general be provided there? So, I guess my first question for you, Kai, is as a practicing a gerontologist out there, what are you seeing happening in your patient population these days?
It's one of those things where a conversation these days can't happen without COVID being spoken about, but really it just has really affected everything we do in a lot of ways. Uh, but now that the world is opening up a little more and patients are able to come in and see their doctors, I would still say that for our older adult patients, it still is a challenge to feel safe enough to come into the clinic environments, but also is it also safe enough to have people come into your home? And I think a lot of people do share that as well, and that level of trepidation, or if not, at least enough background noise to affect their comfortability in having people come to their homes for care. I think that's one of the biggest changes that I see. But also, I would also add to that that we're starting to see more telemedicine and telehealth as
Right,
well.
right.
And I think that's always an option for those persons who feel that that's you know more comfortable for them. And I think that poses a lot of challenges, but also a lot of opportunities.
Yeah, I was actually going to ask you that. In these last 2+ years, I'm sure you saw your percentage of telemedicine visits go up. And is that like a preference right now for older adults?
My practice is all older adults, as you've already mentioned, as a geriatrician, and I would say that it's changed over the 2 year period of the COVID pandemic. At first, when this all occurred, we all sort of retreated to telehealth, and I know that's retreat sounds like a not the correct description, but it felt like that, right?
Hmm.
Viscerally, it felt like we couldn't be in the clinic and in the trenches for our patients, and we retreated to that. And that's the world that I generally view from as a clinical geriatrician, right? Taking off my national medical director hat for just a
Hmm.
moment, right? And it really led me to think about, well, as we've retreated back into telehealth during the initial parts of the pandemic, and to answer your question is, now it's a mixture, right? The
Right.
Omicron surge certainly affected us to kind of go back and do more telehealth visits, but we are primarily now back in the clinic seeing patients. Patients are generally coming in, but we still have anywhere from a good 20% of people that prefers telehealth. And we haven't even touched upon the digital divide for those individuals who don't have a smartphone or an iPad, or really the bandwidth to be able to access telehealth. And so, but oftentimes I think, what what is happening out there in the home based care settings? How are people getting care out there? Because on a daily basis, we do get interactions with home healths, hospices, uh, even caregiving agencies, and there is that challenge of what's going on out there in my mind, as I sit in my relatively protected world of the outpatient clinic.
Yeah, I know it's kind of a crazy time right now. Like we've done first round COVID, we got through Delta, we're in Omicron. Who knows what's going to come down the line. I have always felt like there is a place for telemedicine or telehealth visits who, for professionals who are not physicians. I think that can actually add to quality of care. It can't replace like laying your hands on somebody and really doing a good assessment. But I think there's a happy medium somewhere in there where, adding that type of a layer of a visit really can boost quality. And, it's just a matter of how do we get there in terms of allowance and regulation and all that goes with it. But I do, in terms of a quality uh, perspective, I think there is a good way to balance that out.
Yeah. I mean, I couldn't agree with you more. I mean, where there's a will, there's a way. Obviously, everything else in the regulatory world and in the reimbursement world has to kind of align with that, because, I mean, at the end of the day, it's value-based care, right?
Right.
I think those are things that we all think about, whether we're in the clinic or in the home care settings of most of the people listening at this point. Um, and I think it is a quality piece. It is a uh, patient and family satisfaction piece, and at the end of the day, it's value. And there's got to be a happy medium with that, beyond just having the physicians or providers or APPs do that work.
Exactly. So you mentioned that we're kind of in a like a hybrid mode now where you're doing some telemedicine and we're back out actually doing visits in the community. So how do those visits look like now, in today's environment with where we are with the pandemic? What's different? What's the same? Or
Yeah, it would be hard for me to speak from the standpoint of what home health and hospices do. I do have a subset of my practice in the assisted livings, um, where oftentimes I do encounter in the field home health providers and hospice providers and professionals as well. Um, it Although a lot has changed, I think a lot still remains the same. And
I
I
agree.
think
Yeah.
things that changed, yeah, I think things that changed are obviously the PPE that can sometimes really get in the way of interaction. And I think that's what I think love is the right word. What I really love about taking care of patients where they live. And so what hospices and home healths and home care organizations do. But I think what remains the same still is, when you're with people as patients in their home, they're not just patients anymore, right?
Right.
They it's they're whoever they are in their home setting, And so I think that that's where I think, despite the challenges that have been posed and the challenges that have been imposed
Right.
during the pandemic, really, they don't outshine the foundation of what we all do in the home care setting. So I think as much as they've changed, they've stayed the same, but in a very good way.
I agree with you. I think the focus that community health professionals go out into the home with now is a little more targeted. And it may be that in our pandemic time, I feel like we may have improved that aspect of going into somebody's home and really respecting um, their comfort level and really asking them more about their comfort level.
Yes.
Not just with PPE, but how do you feel like about me coming in? Um,
Yes.
and that, I think maybe that could be something that I hope sticks around after things sort of become pandemic to endemic with COVID-19. So there are some things that I think folks had to do in order for safety reasons, but I hope they stick around. I hope that becomes part of standard practice for home health agencies and hospice organizations and other community-based professionals.
Couldn't agree with you more. I say in sort of a facetious way, but and I heard a lot of people say this is, don't let a good pandemic go to waste. I mean, there, and really there is no good pandemic, right? And that's what I mean, to be sensitive to that, because we
Exactly.
lost we lost a lot of wonderful human beings. We lost a lot of our things that we were used to in sort of our freedoms, if you will. But I think that what builds our resilience is taking these challenges and really seizing the opportunities. So I couldn't agree with you more on really hoping that a lot of these positive things do stay in some way and form.
Absolutely. So now I have the big question for you. What keeps you up at night, Kai?
Oh boy, other than racing thoughts, I think what keeps me up at night is um, not knowing what our patients are going to be challenged um, with the post-pandemic
Hmm.
era. When we're out of this public health emergency, I think that there's going to be a lot of uh, post traumatic things that are going to come out and happen. I think that in a lot of ways I worry about um, you know families and patients actually, after the dust settles, kind of seeing where they're at health wise, right?
Right.
I think our healthcare workers are also going to be feeling the same once the dust settles. Is you know they've been kind of keeping it together during this whole time, and now here's that period of release afterwards, and people are going to have to come to reckon with the stresses and putting aside all their fears and worries. Um, and how's that going to fit in for us to continue the good care that we have to? So I think that's what keeps me up at night.
Yeah, I couldn't agree with you more. I think the healthcare continuum in my read is it's been changing over the last couple of years, but you're right. Like, what is going to be the after impact, if you will, of all of this? And when people that are doing that pressured everyday care are actually going to let down and say, "Oh my God, do I even want to do this, or can I do it
Yeah.
anymore?" And so, that I think there's so many different factors that impact this: patient factors, healthcare worker factors, um, and how this disease is going to look like when it's embed it like the flu, is
Yes,
every year
yes,
into our everyday life. I mean, who's to say what all of this is going to look like 5 years from now, right?
yeah, yeah. The unknown.
The
Yeah,
unknown.
absolutely.
So let's switch gears a little bit. When you're referring one of your patients for care in the home, what are some of the things that are most important to you when you're doing that referral?
Continuity of care. You
That's a big
know,
one.
yeah, that is a big one. But I think there's so many other pieces that connect with the continuity of care, right? So, we, the health system I'm in values connections, values, corporate and clinical relationships, right? So I think that the continuity of care is sometimes connected with that, but I don't necessarily feel that that's the only piece, right?
Mhm.
Because just because you have a known relationship or a known agreement with a health system, it doesn't mean that you're the only one that can provide the care. I think that there are other um, possibilities out in the community that I know through sort of reputation and working with organizations and individuals as well, also in the past, that really does help to build that feeling that the continuity of care will continue, and that the care plans are going to be carried out, and that there's always a good amount of report back, so we can just make sure that we're continuously um, affecting the care in such a positive way.
Right. I have heartburn about continuity of care. I mean, because it just is so important that that patient doesn't fall through a gap,
Yeah,
and as particularly when you're having transitions in care environments, there's so many opportunities for that patient to fall into a gap. And I think if we could just figure that out, if every system could figure out how to keep the patient handed off in a perfectly good parallel way, I think that would go so far in terms of their physical well-being, their emotional well-being, etc.
yeah. I agree with you. I mean, perhaps I'm aging myself to the audience here, but I came out of internal medicine residency in '09 and finished my geriatrics fellowship in 10. And we're talking about 11 or almost 12 years later, and we're still talking about the optimizing the perfect transition, right?
Yep.
And I think that what that essentially, I think the biggest challenge is the complexity of care. And we can't mention complexity of care without really mentioning the aging of our population, and the care needs that comes with that, right? The
Right.
complexity of care that comes with that. So
Exactly. This is nothing anything any clinician should take lightly. It's transition and care. So you told us things that you valued, the continuity of care. Are there any things that frustrate you about care in the home as a physician?
um, I'm gonna answer that question from two standpoints. Um, one as a geriatrician, and one as a primary care doctor. Um, that's a dichotomy for me, because as a primary care doctor, I'm responsible from anything from A to Z for the patient's care. And as a geriatrician, I consider myself a specialist that also happens to be, a primary care specialist. And so when in the roles that I sit in administratively in our health system, um, I sit in the role of a primary care administrator, but also, as a geriatrician. So now that I've spoken about the dichotomy at length here, I would say one of the things that would frustrate me as a primary care provider is not knowing what happens out there. It's not so much that I want to control everything, that I want to control the care, but that I want to understand what actually happens out there and how does it happen out there.
Hmm.
Um, you know, when clinicians and primary care providers are used to being in a relatively controlled environment, right? They see a patient who comes in the home, sees them in the clinic. If something emergent happens, they send them to the ER, then they get admitted. And these are all sort of, quote unquote, controlled environments, right?
Right.
Where these doctors knows generally what happens in these places. And it's because during residency and training, you've actually been to these places. You've actually
Mhm.
had to rotate through and play ER doctor or play inpatient physician. But I would say not a lot of that training happens for the general internal medicine resident or the general family medicine resident who are going to become primary care doctors. And so they may not have that understanding what happens in the home and the care in the home. But as a geriatrician, though, that is very much a part of the training in fellowship, and that's still a part of what I do every day. So, I do have that understanding. But now that I take these two dichotomies and I put them together, I will still tell you that the thought of of the continuity of care, not knowing how that happens out there, and just having the radio silence, and then all of a sudden, ping, you get a fax, or and less common is getting a call, right? Um, but the problem is that this is where knowing enough colleagues, valued colleagues in the home health based care settings, is that it's not easy. It's not easy where our audience sits at, because you know how many primary care providers are that easily approachable? Not because they're mean people, or they're really busy doctors, but you have to get through the call center to get to the doc,
Right.
unless you have their direct number or their direct pager, right? When do you call them? And how do you concisely get all the information you need for them in such a way where you can carry forward the care that you need to? Um, and in cases where there is not that direct communication, then there's that more passive communication of a fax and a signature needed, right?
Right.
And the primary care provider signing off on it. And you really wonder, are people really reading that care plan, and are they really adding anything substantive to the care plan to help with continuity of care?
Yeah, I
Sorry, so
couldn't.
that was a long explanation there.
No, but it had a lot of great points in it. And as a clinician who's been trying to, been 2 feet on the ground in a hospice and has tried to reach out to attending physicians and break through the call center barriers, there is some frustration on that side of the fence as well. Coordination of care is really hard sometimes
Mhm.
in our continuum today to really accomplish. It takes a lot of time. It takes a lot of effort. And I think some clinicians, they just get frustrated. I've left, 8 messages, or I've sent
Yes.
you 3 e-faxes, and I'm not getting anything back. And there may be technology issues on the doc side, or the doc isn't clued in because they don't know what they're supposed to be looking for. There's just so many things that can go wrong when you're trying to coordinate care.
Sure.
And then we have our patient sitting here that we're trying to do the best for. So I think that's
Absolutely.
another thing to figure out. And I don't have the answer to that. Kai, if you have the answer to that, that's the $1 million question.
Yeah.
You could,
I mean, we're still faxing. We're
yeah,
still
right.
using faxes, right? I mean,
Right.
I think that's one of the problems. I will share with you that our health system is actually trying to move to like e-faxes now.
Yeah,
So having a more electronic, but that's a subject matter for another day.
it is. That's a whole nother podcast, Kai, I think, right? All right. Well, I'm going to wrap up with my last question for you, which is talking about community based care providers. How can they gain your trust as a physician?
You know, that's a tough question to answer in a small amount because trust is about relationships.
It is.
Um, Trust is about relationships, and trust is about e- experiences. Um, but and trust is one of those things that you've heard people say. Mentors of mine have said it's not what you do for people; it's how you make them feel that makes them remember you, right? And I think that and how does an organization or an individual gain the trust of a primary care provider who's essentially helping them take care of patients? I would say having a basic framework oftentimes really helps, right? Because there's a lot of themes in this discussion here. Is they're very highly complex patients.
Hmm.
These complex patients that our audience takes care of are generally older adults, right? I mean, there are younger adults too, and children in some cases, but they're generally older adults with complex medical issues because otherwise they wouldn't be on home health and or hospice or needing caregiving services. And having a framework is going to be very important. And what I've been on a journey on in the past 3 or more years is really focusing on uh, age-friendly health systems and age-friendly care. I think that's a nice way of really ensuring that you're providing the quality of care and the continuity of care. And when I think of age-friendly care, I think of the 4Ms framework that have been developed by the Institute for Healthcare Improvement in conjunction with the John A. Hartford Foundation. And the 4Ms of care is starting with the first M is what matters. Um, when care is aligned with an older adult's specific health needs and health outcomes, um, it really helps to have the shared decision making process that oftentimes is needed. Um, the second M to is uh, focusing on medications and understanding it's not just about medication reconciliation, but about determining if medications can possibly interfere with other medications or any medications on the Beers list for older adults. Um, the third one is mentation. For some older adults, there's risks of cognitive deficits and or dementia, coexisting depression, and or sometimes delirium if they've just been discharged from the hospital or a nursing home. And lastly, a focus on mobility is really helping the individual maintain their function um, and being at lower risk of falls and so forth. So, but I think one of the key things here is that when we think about these 4Ms, thinking about them in such a way where it does just work all together at the same time. So, but I know that's not necessarily a nutshell, but I think having a framework is very important.
Yeah, I agree. Having some type of structure is so important, and we'd love to hear more about your philosophy of care. Um, but before that, maybe we could just do a quick summary. Your patients are returning back to receive care, and I do sense that there is some concern about what's next for them via what we've talked about. And really, I feel like you share um, my thoughts about coordination of care and continuity of care being really important as it relates to patients coming back to clinic, uh, uh, community healthcare providers going back out into the community and going back into the homes on a pretty regular basis. These items, I think, need to be a focus even more than they were prior to the pandemic, because I, I think the population in general is feeling a little bit um, they still might be scared. They still may be concerned about people coming into their home, or they may be concerned and scared about going out to clinic. So I think what I heard you say, and what I agree with, is that we really have to look at what the aftermath is going to be, and take a few things like quality focus on continuity of care, quality focus on coordination of care, and really look at those things again in a different perspective, to do better on them, to make sure that our patients feel safe, that they feel connected, that they feel that their care is patient centered, in order to get the care that they need. Did I miss anything, Khai?
No, I think that that's a very nice summary of really what we discussed, and I certainly wish everyone well, and appreciate all the work that everyone's doing out there.
Well, it has been my pleasure to talk with you today, Khai, about soup to nuts here, what you're seeing out there, what we're maybe going to be looking forward to. I guess we just have to see, and just taking the time out from your busy schedule to do Chapcast with us today. And we do appreciate your work as National Medical Director for CHAP. Any closing words or wisdoms or epiphanies for us today?
No, it's just my pleasure. And again, I just want to share with everyone, I really do appreciate all the work that is being done out there in the communities. I think oftentimes it's unsung work because there's been so much focus on things that happen in the hospitals, but we know that a lot happens in the home, in the community. So I'm very appreciative of that, and I certainly recognize it.
Well, thank you, Khai, for all that you do and for making a difference. And thanks to all of you who've joined Chapcast today. We look forward to seeing you on the next Chapcast.